Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello. Thank you for joining us for today's webinar. We are delighted to be partnering with Mark Sharp from BKD to share insights on navigating the financial changes and impacts of the coronavirus pandemic. My name is Kevin Marlowe, and I am part of the video production team. Before we get started, let me tell you a bit about BKD and Axxess. BKD is a national CPA and advisory firm headquartered out of Springfield, Missouri. BKD's home care and hospice team works with hundreds of providers from coast to coast. Axxess is a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Today, you will hear from Mark Sharp and David Hoover. Mark Sharp is BKD's Home Care and Hospice Center of Excellence Coordinator and has more than 25 years of experience assisting home care and hospice providers with financial and operational needs. He is a member of the Board of Directors for the National Association for Home Care and Hospice and is the past chair for the advisory board for NAC's Home Care and Hospice Financial Managers Association. David Hoover is Vice President, Revenue Cycle Management for Axxess. David Hoover is he leads the company's billing, electronic data interchange, and payer management service teams. To date, David's team has processed more than $14 billion in Medicare and managed care claims. Prior to joining Axxess, David served in leadership at Cotiviti, where he developed new processes and systems focused on increased efficiency and quality in auditing, recovery, and development services. Before we begin, a few housekeeping items. Your phones have been muted, but you may submit questions through the chat function. We will follow up with you after the webinar to respond to your questions. Slides from today's presentation, along with the recording of the webinar, will be available after the webinar and will be sent to all who registered via email. They are also will also be posted on both the Axxess and ACHCU websites. Mark and David, over to you.
Good afternoon. This is David Hoover, and wanted to just start off with kind of outlining what's going on with the coronavirus, in the U.S. So January 5th, the WHO reported a pneumonia of unknown cause. So we started kind of the process, and the one thing that is kind of what I noticed about the timeline is how much accelerated momentum that the coronavirus has gotten as it progressed. On January 6th through the 8th, there was a couple of things that happened. DHH created an intra-agency task force related to this finding, this pneumonia of unknown cause. And then Ohio reported its first COVID-19 patient. The CDC issued its first public alert. By the end of the month, on January 31st, another case in California was reported, and the U.S. declared a public health emergency, or PHE, and the travel ban had begun. By the 5th, the 12th case had been reported, so you can see it's moving quite quickly throughout the nation. And then by the 26th, we had the first case reported by community transmission. So that is actually versus it coming from outside the country. It was reported inside the country, a transmission from a patient to a patient. February 29th, the first death was reported. Then it really kind of picked up steam. March 2nd, the cases reached 100. March 13th, the U.S. declared a national emergency. On the 15th, the cases surpassed 1,500. By March 19th, the first stay-at-home order occurred in California. And March 27th, there was a CARES Act passed by the government of the United States to help support businesses and healthcare providers through this public health emergency. On March 31st, 164,620 cases had been reported with 3,170 deaths. And by the end of April, 1.04 million cases had been reported and almost 61,000 deaths. And of course, we've had that continue on the last few weeks. And I did read today that there was, we hit a new milestone worldwide. So what we wanted to talk about was just some of the things that are impacting the financial changes, and Mark's going to talk about some of the financial and cash flow impacts, and then I will finish up with some revenue cycle impacts, and looking forward to figure out how we're going to continue to deal with the coronavirus. Mark?
Well, thank you, David, for that intro on the craziness that we currently find ourselves in today, living in a world of a pandemic that we've never experienced before in the United States. It has really created some difficult issues for all healthcare providers, and that includes home health and hospice providers as well. I'm going to start off just by talking a little bit about what we believe are the impacts on cash and how it can be problematic for you as providers. I do understand that we likely have both home health and hospice providers on the call today. Sometimes you might see that the slides have a little bit of a home health slant to them. Please bear with us. I'll try to do my best to correlate it as well with hospice providers. But the first thing that I wanted to touch on is just the very fact that home health providers already had some cash flow challenges as we moved into PDGM before we even consider COVID-19. And those impacts on cash affect our revenue, expense, and cash flow. And it really all starts under PDGM, the patient-driven groupings model that went into place January 1st of 2020. They reduced the amount of the WRAP payments to 20% instead of the previous 50 or 60% that you would get upfront on episodes of care. So that in itself created some cash flow strains as we moved into PDGM. You couple that with what's around the corner in a year from now when they completely eliminate WRAPs for home health agencies. But you couple that issue with the fact that now we're billing, in addition to the WRAPs that I just talked about, we're now billing final claims at the end of every 30 days instead of at the end of a 60-day episode. We understand that that means we have to accumulate the signed plan of care, physician orders, the face-to-face encounters, and all the information we need to be able to file a final claim. So that has put pressures on cash flow. The very fact that we also have situations under PDGM where our payment rates may have been reduced by the model itself, and or there may be things that we're doing like increasing costs on our intake or producing more claims, so we need more revenue cycle staff in our organization. That could be increasing our cost. Those two things could be decreasing your profit margins. With that, that's going to take a hit on your cash flows. So that's the PDGM perspective. Now let's remember our worlds got turned upside down in March, and David laid out that timeline that we saw, and you all lived and breathed the craziness we find ourselves in. With that craziness, definitely becomes challenges with cash flow. First of all, you're probably seeing potentially a decrease in revenues and cash flow. Why is that? Things such as visits being refused by patients or by staff, fearful of the spread of this virus. And that in itself, when you're decreasing visits in home health, we have many per visit payers. We're just losing out on those visit revenues now. But if you go to the world of home health, if you do fewer visits, you're likely finding yourself having a higher rate of LUPA payment periods in traditional Medicare, therefore decreasing your revenues. On the flip side, if we switch over to hospice, keep in mind that also could impact your revenues with lower utilization on your service intensity add-on payments for the end-of-life care that's delivered. You may find a reduction in your SIA payments. The fact that hospitals basically closed their doors to elective procedures had an impact on home health as well, in that there were less patients coming out of the hospital that needed home health services for those elective cases, such as knees and hips and other elective procedures that have been put off. Likely we'll see a surge on that, but at this point, it has impacted most agencies' revenues. I would also say, in a world where patients and caregivers, families, and the such are fearful of letting people in their homes, there was probably some impact on hospice providers as well, having fewer patients elect hospice potentially. You add that to the things that might strain our cash flow, such as distracted referral sources. Just like you, the whole healthcare continuum has been turned upside down, and referral sources are in that mix. You may be getting fewer referral sources. Not only do you have less access to them from a referral perspective, but also those referral sources are often the source of the documentation we need for billing. That in turn could slow down our cash flow. But not only do we have decreases in revenue and potential cash flow, COVID-19 has also increased the cost of doing business. Things like getting PPE that has been very hard to get for many agencies out there, driving the market price up for PPE. You have investments in telemonitoring. Again, the fear of having somebody in my home has prompted the desire for more telemonitoring. That often takes an investment of the equipment for telemonitoring. The very fact that we're in crisis management naturally puts us in a higher cost situation. We have so much more that we're having to deal with right now that is going to naturally increase our cost. We have most of our back office going remote as we get people out of the work and minimize the potential for transmission of the virus. That means increased technology for our remote workers. And just the very general disruption of our everyday operations has slowed down the productivity. In this environment, where you couple PDGM for home health with COVID-19 and COVID-19 alone for hospice, we are in a position where you have to accurately plan for your cash needs, not only from a long-term perspective, but also the short-term payroll to payroll perspective. So what I'm going to do now is I'm going to walk us through a quick and dirty cash flow analysis on a short-term basis, what you need to do. And I'm going to tell you, this isn't the first time I've done this content in a webinar. And I did have an evaluation come back the last time I presented this, and they said, you know, Mark, that cash flow analysis was probably a high school level cash flow analysis. Well, I'm going to ask you all to bear with me, because overall, the scores that we got on that webinar were outstanding. What I think is I had an individual that really knows accounting backwards and forwards, but I'm here to tell you, for the typical agency, they don't have that level of sophistication in the accounting world. So please bear with me. If this is above your education level, please stay with me. Just know it's reinforcement that it's what you know. So Anytime you're doing a cash flow analysis, you need to look at your cash flow receipts first. You need to break it down into operating, which is basically your core revenue that you get for your patient service. That's going to include your Medicare wraps for home health, your finals for home health and hospice. It's going to include your other episodic type payers, maybe capitated payers for both wraps and finals. And then you'll have your all other payers as well. But not only do you have cash flow issues just with your or cash receipts with your operating, you might have some non-operating as well. And this slide has been changed in error. I can see now as I'm looking at it. But the non-operating are things like rent. Let's say you own your office facility and you actually rent some of that space out. That's not your core business, but it does contribute to cash flow. So you need to remember those types of things. Then you have your financing and investing as well. Those are things such as your draws on lines of credit that you may have or other debt that you might have, as well as it may be the owners are having to put money into the organization. So now let's look at the cash disbursements. The way I break down my cash disbursements is between operating, financing, and investing. And I'm going to show you an example of how this all plays out. But your cash disbursements on operating, your number one cost of doing business is clearly your payroll. So you've got to plan out what your payroll looks like from cash outflows perspective. And then you have all your other vendors, maybe those that you contract with for labor. Maybe it's your accountant, your software company, whatever it may be. Those are the other costs of your operational perspective for things you have to pay for on an ongoing basis. But you might also have some financing outflows, payments on your line of credit or other debt, lease payments on copiers or vehicles. Maybe your owners look to the business as a source of income and they need distributions and or dividends. But you also have investing disbursements, things like actually purchasing equipment like telehealth, as I mentioned earlier, or other office equipment, or the technology that you put in the hands of your clinician. And other business investments. Maybe you're looking at expanding. That would be a cost that you have to consider as well. So with that, what I want to do is I want to walk through real quickly a sample short-term cash needs analysis. And again, from my perspective, we are all in the need to do this type of analysis on a pay period by pay period basis. And you can see it's somewhat broken down into the buckets we've already talked about. This example looks at the 2-week period from April 20th through May 1st. And in that, that's our payroll period because we pay every 2 weeks. So we start with our initial cash balance, which was $15,000 on April 20th. Then we need to consider what kind of additions to our cash flow did we have, our cash receipts. And you can see the amount of detail you should analyze. Think about the timing for which you will likely receive cash on your wrap filings. If you're a hospice provider, you may not have wrap filings. So what about your final claims? Those have different payment timelines, and you need to consider those, not only for your Medicare episodic payers, but also your other Medicare Advantage type episodic payers. Then you have those that you file claims monthly on for all your other cash flow needs. So in this example, in that 2-week period, we expect to collect about $274,000 for our operating revenue stream, which is patient services. Now we need to look at what about the disbursements we're required to make on our operating side. The biggest one, as I mentioned earlier, may be payroll. And again, I timed this analysis with the expectation that our employees will be paid on May 1st. So that gets uploaded into ADP, our outsourced provider in this example, on April 30th. Then we have vendor payments. And I would expect the normal case for you to have much more detail than this. But I'm assuming most pay vendors on a monthly basis, or excuse me, a weekly basis. So you see, I just outlined those payments made the week of April 20th and those April 27th. That's total disbursements of $278,000. Think about the other types of expenditures we need to make. Our automobiles that we lease, the payments are due April 27th of about $16,000. Our office equipment leases due April 27th for about $6,000. Then we have taken out some amounts on line of credit for $1,200, that we have to pay interest on, which is $1,200. So that's an additional $23,000 going out the door in this 2-week period. And again, we're doing this analysis before April 20th so we can plan. If you look at this, we're now in a deficit position. So we're either going to have to go to find a source of debt or go to our owners for capital to help offset that deficit. In this example, we went to our line of credit to get us into a positive cash flow situation. This is the type of cash needs analysis your organization should be doing on an every 2-week basis if your cash flow is tight. But other things you should consider doing immediately in this environment is you need to figure out, again, accurately what your cash burn rate is. And let me just flip back. What would the cash burn rate be here? The cash burn rate would be we're $12,000 in the hole on this 2-week period without going and getting access to additional capital. That's what we mean by the burn rate. To keep your business open, and you need to evaluate that and evaluate what you need to do to break even so you don't burn that cash like we're talking about. So one of the next things you need to do is if you find you're in a deficit cash position and you need to realign your business, think about your cost first. Break them down into variable and fixed and eliminate all non-essential expenditures. Then realign the organization's cost structure to support what you realistically think you will see in the COVID-19 environment. For home health, we've seen them take a hit in their census. Hospice, I've heard some positive, some negative. But the bottom line is we need to know and align what we expect to have in patient volume and get our cost aligned appropriately. If you're thinking about potentially right sizing, and that includes eliminating some staffing positions, be sure you understand their rights under the Families First Coronavirus Response Act. And then lastly, as I talked about, evaluate your options for capital and additional capital that you may need. And here's the 4 buckets that I see that you have most likely as those options. It may start with your reserves and investments. And I'm going to be the first one to tell you, if you're a for-profit business, you likely don't have lots of reserves and investments. Why? Because for-profit entities tend to take their money to their owners quicker. They distribute it back to their owners. So there's not a lot of money in the business if there were a litigation or something like that to the business. Also, if you're a not-for-profit, think about the investments and the reserves. The market took a big hit. Your reserves may be in a place where they're at a lower value today because of the market hit. Also think about donations and contributions that many not-for-profits expect to help fund some of their operations. With the down market, you can expect that there's fewer ready to make those contributions in this market. So then you go to traditional financing. It's never been easy when you don't have lots of bricks and mortar like nursing homes or hospitals to go find traditional financing. We are a service-based business that's really based on a labor cost and not bricks and mortar. So it can be very difficult. AR factoring type loans is about the best you can get. So then you may be going, if you're for profit, to your owners for contributions, equity contributions from them, or loans, temporary loans from your owners. Luckily, the government sees the pressure that we've had, and we have had COVID-19 specific options for you to consider. And I'd like to take you through those real quickly. There are really three: accelerated and advanced payment options, which have recently been closed. So it's really not an option any longer. You have the Patient Protection Program loan, which is the PPP loans from SBA. And then there's the CARES Act distributions, which all of you should have received some of those funds. So let's touch on the accelerated advance payments. These were available upon request from your Medicare administrative contractor. They did it amazingly quick. And this is payment for an advance of up to 3 months of your Medicare revenues. However, it is just an advance. If if you got this accelerated or advance payment, it will be recouped beginning 120 days after you receive the advance payment. And it will be spread out, and they will basically recoup it from your remittance advices. So if you get it today, you need to make sure and plan that 120 days out, it's going to start coming out of your patient revenues. However, as I suggested, the new requests are no longer being accepted as of April 26th. They shut down the program because they felt like there was enough other relief options to be provided. So let's talk about another one of those relief options, the PPP loan program. This was a loan available from financial institutions that are qualified small business administration lenders. What this loan is all about is it's targeted for an 8-week period of your expenses to cover payroll, rent, mortgage, interest, and utilities. 75% of the loan, if you want it to be forgiven, needs to be covered by your payroll related expenses. The loan maturity is after 2 years. So you can have this loan for 2 years at an interest rate of 1%, next to nothing from an interest rate perspective. However, it can be forgiven under certain terms. Basically, those terms are: if you maintain your staffing levels pre-COVID the same after COVID-19, then you're likely to be able to get all or portions of the loan forgiven. By the way, I do want to say that PPP loans, they basically have been diminished. They've been used. There's no additional dollars. I do believe that they are coming out with additional dollars to be distributed in the future. The one that you all should be extremely familiar with is the CARES Act distributions. Basically, our government set up through the CARES Act 100 billion relief funds for healthcare providers. They did 50 billion in general distribution by the Health and Human Services Department, and they did it in 2 waves that you would have seen come out. The initial distribution was April 10th through the 17th. The second distribution to get to the total 50 billion came out April 24th. You have to accept the terms and conditions to keep this money. The distributions will be available to offset COVID-19 related lost revenues to your business and increases in your expenses. However, you have to document it, and it's subject to potential audit or review. And any provider that got over 150,000 in total general distribution dollars have to report quarterly beginning after the June 30th quarter. 10 days after that quarter end, you will have to submit some reporting to HHS, and we don't know what form that's going to take at this point. So those are your options. But what about the long-term considerations? You not only need that short-term 2-week look like I talked about, you need to look out a little bit longer term. 13 weeks sounds pretty short, but it's a lifetime under the current environment we're looking at. You need to consider what that shows in liquidity gaps, when you may need cash flow. You need to make sure you develop a service delivery plan so that you can make sure you are covering the services those patients need. You also need to look at potential vendor payment plans. You might stagger when you pay vendors, drag them out a little bit if your cash flow needs to do that. Also, remember, we need to try to get an employee plan in place to make sure we can deliver the care that's needed by our patients, and then the fear that we have with those employees themselves. So with that, I'm going to turn it over to David to talk about revenue cycle implications.
All right, Mark, thank you so much for that information. Let's see if we can get the request over. Okay, I believe everything's set up. A lot of the information that I'm going to discuss is really from the revenue cycle perspective. You'll hear some overlap from what Mark was talking about. Several of the programs and the impacts are also affecting the revenue cycle, which is the timing of your money. So one thing just I wanted to bring out, it was just the diagnoses for COVID. We have, for the confirmed cases, you have a U07.1 and then the Z20.828 for suspected. If you have some screening for asymptomatic, no known exposure or a negative test or unknown, that's Z11.59. Encounter for screening for other viral diseases is what that actually is referring to. Those are the three main ones. There are some other ones that appear for other manifestations. If you compare it, the COVID should always be in the first position. So if you have like pneumonia or acute bronchitis, you would see the confirmed diagnosis for COVID, and then followed by the subsequent resulting manifestation. So pneumonia would be J12.89 and acute bronchitis J20.8. That is really to make sure that we have a good reporting mechanism for the COVID. It's also, like Mark said, is also some of the reporting mechanisms that would be ways for you to identify impacts or your agencies dealing with COVID diagnoses. Exposure to COVID-19. So possible exposure ruled out after evaluation is Z03.818, and then possible exposure Z20.828, and that's contact with a suspected exposure. If you're doing screening, then it's Z11.59. I'm sorry, go back one. So the next real impact is talking about the suspension of reviews. That was one thing that CMS did as a result, was to suspend the TPE or prepayment reviews. Also the SMRCs, or supplemental medical reviews, and RAC reviews for post-payment. Additionally, they did RCD. They paused it for the ones that were already impacted by RCD, which is Illinois, Ohio, and Texas. And then the implementation of North Carolina and Florida was suspended and will not begin. I have not heard the restart of that at this time. So the one thing that I wanted to make sure that, especially with RCD, is they suspended it and allowed the providers to decide whether or not they wanted to continue with it. Basically what they said is claims submitted without a UTN or unique tracking number would not be subject to that 25% penalty. They'll go through and process. But the one key thing that I wanted to remind everybody is providers may continue to submit the new pre-claim review request during the pause. And that is really with RCD, you were building up from 100% review, and once you received enough information and pass rate, then you could move to a lesser than 100% review. So remember, that is a decision that will impact your revenue cycle currently and moving forward. That RCD claims, once they've been reviewed once, they're not subject to future medical review. So achieving that next level in the RCD and making sure that there's no after or post payment recovery audits is a key consideration to make before you decide to just avoid having to deal with RCD. Also, additional ADRs or additional documentation requests are not going to be received during the PHE, and current ADRs will be released. Most of those, I have seen most of those released already. If there is any out there that are still pending, there's still some ADRs. If there's anything that's suspected, they still may request some ADRs. But after the PHE, post-payment reviews will be conducted, so they're still subject, those claims are still subject to a future review possibly. So realize that in the future, your revenue cycle may be affected by some additional reviews after the public health emergency is completed. I'm sorry, it's going on. Have a little difficulty. So another impact on the revenue cycle is the telehealth services. You know, that's been a big question that we keep receiving and questions about it. So CMS reimbursement changes that happened for COVID and for the coronavirus were very specific to physician services. The reason being is that home health, really post-acute, it's not designed and it's not in the regulations to allow for telehealth services. So it actually would take a change in the law versus what they removed were changes specific to physicians, which already had the ability to bill for telehealth services. So, but home health can utilize telehealth services to perform those services. So it does allow you to deal with continuing to service your patients and complete the level of care that they needed through certain telehealth. It also protects not only your staff, but also the patient from any unneeded exposure. The one thing that it does, it must be included in the plan of care and it must be documented in the chart. And again, like I mentioned, it's not reimbursable by law and it can't qualify for an episodic visit or a separate visit. It should not be included on the claims, but the cost can be included in the cost report. And I think that's one thing Mark talked about. There are some investments in telehealth that could potentially, you know, can be reported in the cost report and subsequently help you raise rates in the future. Physicians can use these face-to-face and certifications. So hopefully, you know, we'll see more ability to get the providers to allow us to have quicker resolution for those billing requirements that we need. So that is one of the benefits to having some telehealth services. I know the biggest thing is qualifying for the episodic payment. And those visits still have to be done at the patient's home. But once you meet the LUPA threshold, then the telehealth services can definitely take over and be performed. So let's talk about some of the scheduling and LUPA impacts. So one of the things that was removed is the requirement for on-site visits for home health supervision, which is, you know, a great thing, and it saves some time and energy, but a lot of agencies use this as a visit to qualify for the LUPA. So be careful about, removing that visit, because usually those supervision visits were also used for nurse visits also. So be careful and be aware of that might cause LUPA if you're no longer scheduling that supervision visit. Also, a big thing that's out there is patients refusing services or allowing on-site visits, which is causing the zero visit billing periods. So two things a RAP does is, of course, get you a money on the front end, the 20% on the front end, but it also updates the common working file. So the agency is recorded under the common working file. So a couple of things, there are CMS guidelines for a zero visit billing period that you should submit the RAP even though you don't have a visit, get it denied because there's no final that's going to be submitted. But there's some caution that you have to think about this a little bit more in depth. That is going to cause cancellations. That is going to potentially have your RAP cancellation rate be increased. My suggestion is just really the communication with the patient is really the key. Trying to make sure that before any services or any effort is done that we understand whether they will allow or not allow visits inside the home, whether that's in the first billing period or the second billing period. That is one of the main things, so that you don't expend any effort or cost without the ability to get compensated. And we'll talk a little bit more about that in the next few slides. So another thing that was changed was the other provider utilization, really talking about nurse practitioners, physician assistants, and clinical nurse specialists. And just a reminder that these are subject to state laws. Federally, they were allowed to perform different services, but there are state laws that restrict their practice acts. So, but these providers can order home health services, they can establish, review, and sign plans of care, they can certify and recertify. And that process is for claims with a through date of March 1st. So it's not just the start date, it is the through date of March 1st. Hopefully, and I think the intent of this was to speed up that process to make sure that you were getting the information that you need timely, effectively, so that you can get the billing and what you needed done out of the way. So hopefully your referral sources are utilizing these other providers, and if not, then hopefully you can communicate, and maybe there are ways to ensure this gets done. One thing that I did want to mention, and I know Mark started the presentation off talking about PDGM, but we still need to be preparing for PDGM, and really the COVID situation has kind of given us an opportunity to do more adaptation for PDGM, but we still need to be preparing for when PDGM has its full effect. So the 5-day NOA, Mark mentioned that the RAP will be going away, at least the payment for the RAP will be going away by the end of the year. It will still be required as a notice to CMS to update the common working file. And then the following year, it will move to a notice of admission, and there will be penalties associated with late submission. So we need to make sure that from the admission down to the filing of that NOA is happening quickly. So we need to make sure that intake information and collection is done, as quickly as possible. We need to talk about, 30-day billing periods and making sure that we can capture all of the final information appropriately. So that is another process to make sure that the billing, all the requirements are done and processes are in place to ensure orders and visits are completed so that we can get the billing out as quickly as possible to help cash flow. Intra-episode management and 30-day reviews. I know that I have other people with Axxess clinically talking about 30-day reviews, but there's also a revenue cycle component of there to make sure that everything is required, and we'll talk about that a little bit more on the next slide. The other thing is really looking at analysis and reporting and making sure that everything is there for your agency to understand what PDGM is. If you're having changes and altering your revenue cycle, that you understand what it's doing and how it's doing it. That way you can align your revenue and your expenses a little bit better. So understanding the source and timing of PDGM, which affects your reimbursement from PDGM, understanding your mix of your clinical grouping. There were a lot of agencies, I think, that as you started looking at PDGM, there may be some different clinical components and groupings that you may want to have expanded on. Functional impairment, I know that we've seen that as one of the biggest opportunities. Not sure that we did the best job before PDGM, but it is a key component to the reimbursement. So making sure that you're understanding that the functional assessments and impairment election are accurate. Comorbidity adjustments, again, is not as impactful as functional impairment, but definitely need to understand how your patient and how your patient base is looking as far as comorbidities, just to make sure that you understand where the additional money may come from. LUPA management is a key component of this, especially right now. We're expecting increases in LUPAs with PDGM, and now we're even in more with COVID and coronavirus, but trying to make sure that you understand that which visits are going to be LUPAs, and make sure that you know about those on the front end. I think the unexpected LUPA is the one that's really dangerous. The expected LUPA, you can manage your expenses appropriately, you can manage your mix a little bit better, but the unexpected is the ones that you need to focus on. Also talking about average episode length and average visit per payment period. Those two things we're probably going to see evolve and change with the new reimbursement methodology from the old episodic payment methodology. So just making sure that you understand and have a good reporting as this evolves, because I think it will take some time before you see the full final adjustment and changes as they come with PDGM adaptation. So let's talk real quick about the 30-day process. I think this is a key component when dealing with PDGM is, making sure that before the end of the 30-day that you start recognizing the things that need to be done. The fastest time that you can take action to make sure that the appropriate requirements for billing are there as close to that 30-day, the better off you should. You're better off, your cash flow will be a little more consistent it will be. So suggestion that you have, like on day 25, you should start your first 30-day review process. So it should occur before the prior to the end. It should occur prior to the end of the period. You need to make sure that your wrap is processed. You need to identify any unsigned orders, and then push to get those signed. And hopefully you can use some of the other providers that are out there to try to get some of that accomplished. You need to ensure the face-to-face is completed. You need to make sure that the OASIS has been accepted. So again, trying to make sure that everything is in line. All visits have been completed and documented by your clinical staff. And then also review any possible changes in focus for the subsequent 30 days, because in PDGM, remember that you can actually change what your payment is if you're changing focus. So if a diagnosis or your primary diagnosis that set the rate for your reimbursement during the first 30-day resolves, and you move to the subsequent diagnosis, then potentially your payment and reimbursement may be affected. So I think all of those things should be reviewed on that 30-day review process, along with some clinical information too. So I think moving and having your agency and your operations think about in 30-day processes to make sure that this is resolved will be a key moving forward. So I believe that was the end that we had. Molly, I'm not sure if you're available or if you want to have any conversations about this, or Mark, did you have any final words?
Well, what I would say, David, is I think based on what both you and I have presented is it's definitely a challenging time. And we do know that hopefully the CARES relief funds, emergency funds have been provided, will be very helpful in bridging the gap during this difficult time. And there definitely is some requirements that come with that, but stay tuned to those requirements. And I think hopefully, as long as this pandemic doesn't carry out over too much longer into the fall or anything like that next year, that it'll be a very nice thing to get back to the norm. But in this difficult times, definitely be very mindful of the cash flow needs that your business will likely have.
Yeah, I agree with you, Mark. And my sentiments exactly, recommendation is think through all these things. There's a lot of changes happening very quickly. And we want to make sure that, understand the impacts, understand that business will go on and continue to go on in the future. And, just keep preparing and working through those operational issues and challenges that you have.
I think it's very important that you stay in tune with all the changes, and just participating today tells me that your organization is one of those that looks to organizations like Axxess to help keep you informed, and I urge you to continue to do so. As David said, things are changing almost by the hour with some of these issues.
Okay, Mark and David, this is Kevin again. Molly apparently can't get in right now, but there are 4 questions that came in. Did you want to try and answer those right now?
Sure.
Okay, so the first one says, regarding CARES Act provider relief, $50 billion program, initial $30 billion was sent to all. Is the subsequent $20 billion of the provider relief optional? As it's indicated, we have a deadline set for June 3rd to file.
Yeah, basically the answer to that is hospice and home health providers that have a Medicare payer mix above at least 35%, which all hospice providers do, most home health providers do, and we're talking about traditional Medicare payer mix. You would not have received any additional funds in general distribution, in the second general distribution. So you really, if you're in that boat of being greater than 35% traditional Medicare mix, you shouldn't expect anything more under the general distribution that's out there today. So be sure to continue to do all your attestations and do your proper monitoring of your lost revenue and COVID related cost increases.
There's a second part to the question. Says, how is the subsequent wave different from the initial money received?
Well, it's kind of a complex situation. I'll see if I can explain it. The first distribution was done just to get money in providers' hands, and they used Medicare claims as the basis to do it. It was intended only to be an interim step. The second distribution was all of the 50 billion as it was intended to be distributed in the first place, using total revenues. So the first distribution was on Medicare only. The second was on all your revenues. However, the way it worked is home health providers and hospice providers got more than they would have gotten based on the formula of the second distribution. At one point in time, we thought they were going to have to pay some back. HHS said, no, we're going to hold them harmless. No harm, no foul. Keep the extra money, and we'll move on down the road. hopefully that explained it. It's a little more complicated than that to answer a 2-minute question.
Okay, I think we're just going to do one more because there's more popping in, and we'll follow up with everyone offline after this, but we'll do one more. How long will RCD in Illinois be paused? Any idea?
So like I mentioned, we haven't heard of any resolution yet or to when the pause will stop. But we're as soon as we do, we definitely are going to let everybody know. Like I said, I think that until the PHE is actually removed, then we're probably going to see the status as is right now. With all of the CMS changes and things that are going on. We potentially might even have some additional funding. I think Mark mentioned that too. As long as we are still experiencing the public health emergency, we're probably going to still keep under these rules and regulations right now, including the delay in RCD.
Okay. Well, like I said, we will follow up with everyone else's questions offline after this. But thank you, Mark and David, for sharing your thoughts and wisdom with us today. Don't forget, we will also provide everyone with a link to the slides and post a video recording of the webinar on our website, axxess.com. Thank you all for joining us today as we deliver our mission to empower healthcare organizations and professionals with the world's best technology solutions.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.